Thank you very much, Tom. It's a pleasure to be here today, and to almost everybody here who I don't know, I'm glad to meet you, and please introduce yourself at some point to me. I've been here 2 months, and so they figured I was a good candidate to be a victim for Grand Rounds. So today I'd like to talk to you about oxaliplatin neurotoxicity. In fact, one of the things that people ask me more than anything in the world is, what about calcium, magnesium, and oxaliplatin? So hopefully we will get to that as well. Okay. So I have some disclosures to make. I consult for a number of companies. I don't think it represents any conflicts of interest since I'm an equal opportunity consultant. So in terms of the history of treatment of colorectal cancer, you can see here that 5-FU was the original drug for the treatment of colorectal cancer, and it was a drug that really we continue to use today, but it was pretty much the only drug until the late 90s. And people built their academic careers on which way you could give 5-FU. Should it be bibolus? Should it be infusion? Should it be modulated with leucovorin? Should it be modulated with methotrexate? Should it be modulated by interferon? All kinds of things. And really not much changed in the treatment of colorectal cancer in terms of outcome until we started adding some new drugs, such as irinotecan, oxaliplatin, which wasn't approved in the US till much later, but approved in France in 1997. And then biologics with bevacizumab and cetuximab. But I would like to address one of the key problems that we're facing today in clinical trial development colorectal cancer, is how to combine biologics with oxaliplatin. So again, just to fill in a little bit of the background for those of you who are not cognoscenti of colon cancer, 5-FU, this is the original patent filed in 1957. So a few years ago, we had a sesquicentennial symposium at NYU for 50 years of 5-FU, and it was a rationally synthesized drug. They took a DNA-based uracil, they added a fluorine, and figured it could inhibit DNA, and in fact it did, and we still use it. And as I said, people spend a lot of time learning how to give 5-FU in different ways. But the thing that has tended to influence our current treatment are these kind of hybrid bolus infusion schedules from France, mainly started by Amory de Gramont, where 5-FU was given after leucovorin 2 days in a row, or finally 1 day on the simplified LV5-FU2, and then people added oxaliplatin or irinotecan, and we kind of got the full Fox and full theory variants. And as we can see here, 5-FU by itself continually through the years pretty much gave a 12-month or 12 to 13-month, 14-month median overall survival. And things really didn't start changing until we added these additional drugs with irinotecan or oxaliplatin. And one of the most influential trials for U.S. oncologists was this U.S. intergroup study N9741, presented by Rich Goldberg at least 5 times at ASCO over the years, showing that the overall survival was greatest with oxaliplatin-based therapy, which has pretty much given oxaliplatin the role of first-line therapy in the treatment of colorectal cancer today. So again, single agent had median progression-free survival or time to progression of about 5 months, median overall survival of 12 to 13 months. But when we added another active drug, we were starting to see 17-month median survival. So this is oxaliplatin. It's a 3rd-generation platin. Cisplatin was discovered by a chemist who was working in electrochemistry and with platinum electrodes, and this is an organoplatinum where when it's injected into a human or into aqueous medium, the chlorines are leaving group, and you land up giving this diaminoplatinum adduct to DNA, and that causes the DNA damage. A decade later, we came to a 2nd-generation platinum carboplatin, which had an organic leaving group, but the DNA adduct was the same. This diaminoplatinum caused the DNA damage. Even though it changed the toxicity spectrum considerably, the activity is really not too different. And then oxaliplatin has this large, bulky group here attached to the amines that prevents mismatch repair enzymes. So this kind of substituent on the amino groups, called the diaminocyclohexane aminoplatinum, prevents mismatch repair enzymes, and therefore this drug is particularly active in colon cancer, where we have a lot of mismatch repair activity, whereas the other platinums are not very active in colon cancer at all. And as we could see in this analysis performed by Axel Grothe and Dan Sargent from the Mayo Clinic, if you graph trials that had either 5-FU alone or drugs combining irinotecan or oxaliplatin, the survival tends to get up towards over 20 months, median survival. The thing that correlates with it is not which drug you gave first, but the fact that the patients had access to all three drugs. So the more that patients were able to receive first-line therapy and second-line therapy with active drugs, and combined with 5-FU, then their survival became longer. However, if you look at the regression line here, even if 100% got all three drugs, you'd still expect a median overall survival by this regression curve of only 23 months. And we're getting beyond that today with the use of biologics. So the biologics, this is a modification of some conceptual underpinnings of different ways that cancer cells can be treated and can act differently than normal cells. And the one I'd like to focus on is just angiogenesis with the use of bevacizumab. I think everybody here knows bevacizumab, or Avastin, is an antibody, a monoclonal antibody that binds vascular endothelial growth factor and reduces or prevents angiogenesis. So this was the pivotal trial where a combination of irinotecan, 5-FU, and leucovorin was combined with either placebo or bevacizumab. And this showed a very remarkable hazard ratio of 0.66 for overall survival. And that's about as large a survival difference as anything we'd seen in colon cancer for a long time. And as you can also see, the progression-free survival went up from 6.2 to 10.6 months. So that was a hazard ratio of 0.54, which is even more impressive, and a somewhat improved response rate by 10% also. So this shows that biologics such as bevacizumab can really improve first-line therapy in colorectal cancer, but there is a problem with oxaliplatin, and that is its cumulative neurotoxicity. So FOLFOX has emerged as the standard first line, but we have dose-limiting cumulative neurotoxicity of oxaliplatin, and when you add a biologic, you might like to improve survival by a third, but if you land up developing neurotoxicity before you can get the maximum benefit of your biologic, you'll never be able to see that benefit. And for example, the IFL plus bevacizumab, the progression-free survival had a hazard ratio of 0.54. So for FOLFOX, you'd expect a progression-free survival going from about 8 months to more than 12 months, and that's just not possible because you can't even give 8 months of oxaliplatin, yet alone 12 months. And we see this very nicely in this toxicity analysis of the N9741 trial. So 63% of patients on the FOLFOX arm discontinued for reasons other than progression. And that was mainly due to neurotoxicity or myelosuppression, which can be dealt with pretty easily. But the neurotoxicity was the main reason that people went off treatment that can't be addressed so much. And you can see here that here's the time to progression of 9.3 months in that arm, but the time to treatment failure, the median time to treatment failure that patients went off oxaliplatin for toxicity was about 6 months. So that's a fairly large gap and does present a problem with how to deal with this. And as you can see here, the incidence of grade 2 and 3 toxicity goes up as you get to higher doses. This is 12 doses. So as you're going from 8 to 10 to 12 doses, you can see the incidence of grade 2 and 3 neurotoxicity is going up. And while the between 800 and 1,000 milligrams per square meter, the neurotoxicity rate doubles, most of the responses are already seen by the time you get to 800, and generally people started stopping treatment well before 6 months. And again, in this analysis of 9741, the time to progression was a median of 9.3 months. The time to treatment failure was about 6 months. The time to median time to response was about 3 months. And the time to grade 2 and 3 neurotoxicity was 6 to 7 months. So how can we deal with this problem of oxaliplatin neurotoxicity? Well, one thing is to understand the biology better and maybe deal with it. Oxaliplatin really comes in two flavors of neurotoxicity. One is the acute neuropathy, which everybody gets the first time they get it, and it's a transient cold-induced paresthesias where their fingers will tingle and burn if they go in the freezer, touch something very cold, or if they drink something cold, kind of feels like an ice pick in the back of their throat. And this is very common. It's not dose limiting. It tends to last a couple days, and we tell patients to wear gloves in their freezer and not drink anything cold. But as they continue treatment, they develop this more cumulative neurotoxicity where the neurotoxicity lasts longer and longer and eventually isn't cold-induced, and patients begin to develop a sensory neurotoxicity which limits their activity and ability to function. And that's when we start to decrease the dose of oxaliplatin or discontinue it. And in fact, when we talk about grade 3 neurotoxicity, it's interfering with function according to the NCI-CTC criteria. And then there's also a little bit of a delayed neurotoxicity, which is sometimes called coasting. We see that a little bit with oxaliplatin. You see that with all chemotherapy drugs, that after you even stop, especially in the adjuvant setting, you get up to 12 cycles, they don't have much neurotoxicity. You see them 2 months later, and it's very bad. So sometimes it comes on late as well. So this was investigated early in the life of oxaliplatin in France by Eric Gamelin, who happened to be married to a neurophysiologist, Laurence. And she said to him, well, this is just like myotonia. It's like a hyperesthesia or a hypersensitivity of the neurons. And so they started looking into this, and they thought it could be a channelopathy because that is the mechanism of myotonia, where the sodium channels open up, and that causes an irreversible nerve damage eventually. And we think that's due to the oxalate leaving group. Again, there's the structure of oxaliplatin. We have this organic leaving group. And the oxalate, as I think many of you remember from chemistry, is a bivalent chelator of cations. So we think that when the oxaliplatin becomes aquated and you get the diamino DAC platinum leaving group, you also get oxalate, which can chelate the calcium and open the sodium channels and cause nerve damage in this hypersensitivity. And this has been looked at by neurologists. You can see reduced sensory conduction velocity and sensory amplitudes of nerve conduction when you give people oxaliplatin, and again, sensory evoked potentials show the nerve damage, and it can be associated with Lhermitte's sign. And then there are morphologic changes in the dorsal root ganglia and the sciatic nerve after repeated doses of oxaliplatin. So these are all some of the biologic evidence that go along with the neurologic findings. Now, one thing that's important about the oxaliplatin neurotoxicity is in looking at these data from the Mosaic trial, which was an adjuvant study. So these are patients who could be followed for a long time. Most of them did not get recurrent colon cancer. And here is the neuropathy at the end of treatment and then in 6 to yearly intervals going forward. So you can see by the time you get out to 3 to 4 years, there's a little bit of grade 1 neuropathy left, only in 12% of patients, and minimal grade 2 and 3. So 85% of people will eventually have their neuropathy return to grade 0, but you still got 12% of people 12 to 15% who have some degree of neuropathy left as a long-term side effect. So one way to improve tolerability was this stop-and-go strategy, which was also developed by Amory de Gramont. And he said, well, what we need to do is give people a lot of oxaliplatin up front and then stop after a few doses and then restart the oxaliplatin when the tumor starts to grow again. So they did this trial in the French cooperative group Gercourt looking at what they called Optimox, which was to optimize oxaliplatin by giving a high dose for 6 cycles, then stopping the oxaliplatin and continuing 5-FU, and then restarting once the tumor began to grow again. And again, this is without bevacizumab because this was before bevacizumab was widely in use and approved drug. And then in a follow-up study, the OPTIMOX-2 trial, which was an attenuated trial because bevacizumab then became commercially available, looked at this same OPTIMOX schedule versus a complete break, a chemotherapy-free interval. So what we could see in the first stop and go, or the OPTIMOX-1, was comparing continuous FOLFOX to this 6 doses of high-dose oxaliplatin and then 5-FU leucovorin for 12 doses. The progression-free survival was not much difference. The duration of disease control, which was something Dr. Degremont invented to include the first progression-free survival interval plus the second progression-free survival after you reintroduced the oxaliplatin so you could make up for stopping early, was equivalent. And in fact, the overall survival was equivalent, but there was less grade 3-4 neurotoxicity with this strategy, so that was a positive study. And here you can see a graph of the incidence of patients with grade 3 neurotoxicity in the yellow for continuous FOLFOX4, and then in the blue for starting with high-dose oxaliplatin and then giving a treatment break and reintroducing. Of course, most people couldn't quite understand Dr. Degramont's criteria for restarting the oxaliplatin, and as he always says, they failed to reintroduce the oxaliplatin, and so the results were not as positive as he would have liked, and he would said that it would always be much more positive if you actually reintroduced oxaliplatin. However, when you stop chemotherapy altogether and give this chemotherapy-free interval, what you see here is that the arm where you stop chemotherapy, everybody progresses much sooner than even with the second progression allowed, and you do need some maintenance chemotherapy. And in fact, it was very close to being statistically significant, even with a very small sample size. So at this point, we probably learned that you shouldn't stop all treatment. And we saw this theme carried out again in this very large trial. It's probably the largest metastatic colon cancer trial ever done. It was sponsored by Roche internationally in various continents and globally, which was originally supposed to be a non-inferiority trial of CAPOX versus FOLFOX, so capecitabine and oxaliplatin instead of 5-FU and oxaliplatin. But then when bevacizumab became available, it was a randomized 2-by-2 trial. So altogether, there were 2,000 patients in this trial, 600 on the initial and 1,400. And as you can see here, the problem with this study was that the 5-FU and the bevacizumab was not continued really beyond the oxaliplatin. Everybody stopped around 6 months. There was very little additional drug given, and that was quite different than the IFL trial, which showed the big benefit because people who got IFL plus bevacizumab went on to continue treatment much longer. So in the end, this showed an equivalence of CAPOX and FOLFOX and a small benefit for the addition of bevacizumab to FOLFOX, but not as much as one would have liked. So this was a trial that showed a little bit of benefit. It was statistically positive, but that was mainly due to the fact that it was a huge trial. So what else can we do? Well, could we come up with a neuroprotectant for oxaliplatin? So it's something that would not interfere with efficacy, it would be tolerable, should reduce the overall neurotoxicity and severe neurotoxicity and give you a higher cumulative dose. So that's kind of the ideal neuroprotectant, which we don't have yet. But Dr. Gamelan, again, with his wife, said, well, if it's the calcium being stripped off by the oxalate, why don't we give some calcium and magnesium before and after the oxaliplatin? And they came up with this calcium-magnesium regimen to protect against oxaliplatin neurotoxicity. So they presented some data back in 2004 in Clinical Cancer Research, which was a retrospective study of people getting calcium, magnesium, or none, and it was not randomized. It was just what they had been doing at their practice in Nantes. And you can see here that the patients who got calcium, magnesium had much lower rates of neurotoxicity. And in fact, they had similar efficacy results. So this became of interest and began to be used widely in the US. but it had not been studied prospectively in a randomized trial. So we put together this concept trial in order to optimize FOLFOX and bevacizumab and to test in a randomized double-blind fashion whether calcium magnesium would be effective. So this trial, which I conducted together with Axel Grothe from the Mayo Clinic, was supposed to accrue 532 patients, and it would be a 2-by-2 design of continuous FOLFOX versus a stop-and-go type approach, or an intermittent oxaliplatin with or without calcium magnesium in a double-blind fashion where only your pharmacist would know for sure what you were getting. But the study accrual was going slowly, so the study size was reduced, and then people said, well, we already know calcium magnesium works, so we don't really have to do it, and so we were forced to kind of modify the study. And shortly after that, the DSMB interrupted the study for a question of efficacy, so that became the problem. But in this study, what we did was gave 8 cycles of oxaliplatin at 85 per meter squared without a bolus. That's why we called it modified FOLFOX7, but it had the lower dose like we use in modified FOLFOX6. So 8 cycles or 4 months with oxaliplatin, 4 months of 5-FU-leucovorin and bevacizumab for another 4 months, and then restart the oxaliplatin automatically. At the 2-month point in the middle here, if the tumor was regrowing when you scanned, you could restart the oxaliplatin sooner. So the first question was, as reported by the DSMB, did calcium magnesium interfere with the rate of response? Well, response was not an endpoint of this study. The primary endpoint was time to treatment failure, so we didn't even include response as a datum reported by the investigators. So there was no primary evidence. But the DSMC decided to look at it, and they looked at some CRO reported response rates based on somebody's reading of radiology reports. And also it was contaminated by a number of additional patients who got calcium magnesium in the non-randomized group. So what we did was we went back to the actually randomized patients at the time the study was stopped, and that was about 70 patients per arm, and we gave all the scans to an independent radiology review committee, and they reviewed it, and as you can see here, the group with calcium magnesium did not have a lower response rate. There was no negative effect for calcium magnesium, and in fact, the intermittent group seemed to do better in terms of response rate. So that was the first thing, but based on independent radiology review of the actually randomized study patients, there was no effect on activity. And we did write a letter in JCO that said this might be the case, but when this was presented at ASCO GI in 2008, we could say definitively calcium magnesium does not interfere with activity. And then in terms of the time to treatment failure, so which was the primary endpoint, you can see here that if you give the FOLFOX continuously, the median time to treatment failure was only 4 months, but with this kind of intermittent approach of restarting, it was 5.6 months, and the hazard ratio was 0.58. So you really can get a lot more oxaliplatin in by adopting an intermittent strategy. And in terms of progression-free survival, again, a very large difference in time to progression with a hazard ratio of 0.53. So just cycling the oxaliplatin in a reasonable, clinically reasonable schedule can have as big an effect as giving bevacizumab together with FOLFOX, maybe even more. And in terms of neurotoxicity, again, there were fewer events and less neurotoxicity in the intermittent group, as one might expect. Now, at the same time that we did this study, the North Central group was doing a adjuvant trial with calcium magnesium. So this was just with adjuvant FOLFOX. This study actually should be coming out in JCO pretty soon. I know that it was accepted for publication, and you may see this in the next month or two coming out as an early publication. So in this group, patients who received adjuvant FOLFOX were randomized IV calcium magnesium or placebo, and again, it was double-blind, and the primary endpoint was the percent of grade 2 sensory neuropathy. You can see here that there are 2 different scales. One's the oxaliplatin scale, one's the CTC scale. This is, if you start to have it continuously, it's grade 3 here. It has to interfere with function. And you can see that the calcium magnesium had a statistically significant effect on reducing the severity of neurotoxicity in the 100 patients. Now, this should have been a much larger study, but again, it was stopped at the same time that the concept trial was stopped by our DSMB because everybody was concerned it would affect activity. And here are the Kaplan-Meier hazard curves for time to grade 2 or 3 sensory neurotoxicity, and on the two scales, the NCI scale and the oxaliplatin scale. And here are patient-related outcomes, PROs, for oxaliplatin-induced side effects, sensitivity to touching cold items, discomfort in swallowing cold. And you can see that when you get the calcium magnesium, even according to patient perception of how bad it is, you seem to have a benefit that gets a little bit more pronounced as you go on to longer cycles. Another trial that was looking at this calcium magnesium is this one done by Gamelan. This was presented at ISGIO, but it hasn't been published. It was also a letter in JCO, but it was a small number of patients, only 26 in each arm, but again, they showed no difference in activity and less grade 3 neurotoxicity in the group getting calcium magnesium. We're still waiting for this to be published. So let me just skip over this, but this is some glutathione S transferase polymorphism data that suggests people with this may have a little bit of lower incidence of neurotoxicity. And excuse me, while we get rid of that drug, because zaliprodin is no longer being developed, but that was another nerve growth factor stimulating drug that thought to maybe protect against neurotoxicity, which didn't work either. So let me just conclude by telling you that cumulative dose-limiting neurotoxicity of oxaliplatin reduces the long-term utility of this agent, particularly when it's used with biologic or targeted agents. In the concept trial, the efficacy was not affected by calcium magnesium, and it did suggest a neuroprotective effect. Intermittent use of oxaliplatin, such as we did in the concept trial, gave a significant improvement in time to treatment failure and improved progression-free survival compared to giving oxaliplatin continuously. And we also saw evidence of neuroprotection in this adjuvant trial, NO4C7, which you use two different scales and also quality of life parameters. And again, this is all very convincing. Even though it was a small study, it did show a statistical effect. So due to negligible toxicity, low cost, and lack of interference with the chemotherapy effect, calcium magnesium could or should be considered a standard treatment. At the moment, we don't have a better neuroprotective agent, so I think the best option today is to use calcium magnesium and intermittent use or stop-and-go type approach of oxaliplatin in combination with Avastin or bevacizumab-containing regimens. And I will conclude.
Thank you, Howard.